Good afternoon. My name is Tina Azer, and I'm the Vice President of Market Leadership at EXL Health. My areas of responsibility include ensuring that EXL's design and executes comprehensive innovation programs that really fit the industry needs. And I do that by really watching trends, insights, and policies. In addition to that, I'm really excited to be able to speak with the Blues participants today. I have spent 23 years in payment integrity, and the last 15 really serving the Blues community, playing a really heavy focus on ITS claims, both from a life cycle of a claim as well as cost containment around those claims. For those of you that are new to EXL or are not familiar with us, we are a global company organization founded in 1999. We're in the health sector, started in 2015. And today we have over 33,000 employees worldwide. We really believe in using our deep domain expertise with analytical insights and technology-enabled services to really transform how care is delivered, managed, and paid. Today, we have over 800 customers. We work with payers, providers, life science groups, employees, PBMs, and we really focus on enabling a better patient and member experience that improves the quality and outcomes and efficiencies around care. We also have a comprehensive initiative to really help payers and providers with cost control, really looking to reduce overall health claim expenditure while optimizing revenue and opportunities and really improving patient experience. And lastly, we have a new advisory service arm that really offers consultative support, given some new tricky policies that we have out there in the nation. Today, we're going to talk about the No Surprise Act and the Price Transparency Bill. I really hope today is of value to you. I also hope today is just a little bit more of a dialogue or interactive. At the end of my presentation, we'll open up the lines. So I really encourage you all to reach out with thoughts or chats. It's been far too quiet out there in the industry around these issues. So I'm excited to get at it today. All right, let's just talk about the No Surprise Bill. So we are now seeing where legislation is speaking to the consumer's need for digitization and where really the broken economics of healthcare can only get resolved through adoption of data integration and reform. 28 million Americans exhausted their savings during 2021. Just for reference, that's roughly the population of Texas. What's more than that is 42% of millennials now have medical debt, while seeing their health decline faster than previous generations. They are also paying about 33% more for that care. Now, those millennials are really experiencing the US healthcare for the first time during a time where there's things like high deductible plans. And those things have fostered their needs to know the economical outcomes of their care. The perspective of today's patient has changed. New patient mentality, along with public policy, have really created an environment where digital innovation is just no longer luxury attributes, but they are minimum requirements for care. 1 in 5 medical claims and 1 in 6 out of every hospitalization in the US includes a surprise bill, and they are the primary driver to medical debt. Now, for those of you that are maybe not familiar with it, a surprise bill occurs when a patient receives a bill for care, typically where it's not part of their network. And it oftentimes occurs when the patient did not know because they didn't have a say where they were receiving care. Another way a surprise bill occurs is where it occurs in an in-network setting, but from an ancillary provider who is not a network. So you're going in for your knee surgery and you receive surgery, but your anesthesiologist is out of network. The No Surprise Bill was signed into law and it goes into effect January 1st, 2022. The largest impact of this piece of legislation is that it removes the member from the equation. and they can just no longer be balance billed for those services unless the patient completes a notice and consent exception. And we're going to talk about those just a little bit later. The new law applies to individuals, group health plans, including fully insured plans sold through the individual market and group markets, as well as self-funded plans. Now, that legislation is going to look for payers and providers to apply existing state laws so long as they meet the mandates of the federal legislation. And if there's no law on the book, then the federal law is going to look to apply the QPA, which is the qualified payment amount. Now, that qualified payment amount has been one of the pieces of this legislation that's probably been the most disputed, right? It landed last week. It's going to be the median of the contracted rate of the planner or issuer for the item of service in that geographic location or region, okay? Under this, a plan can deny payment, file a claim, and then engage in about a 30-day window of open negotiations. Then that claim goes to an IDR, which is an independent dispute resolution to determine payment. Now, that IDR panel really is arbitration, and those arbitration events can be pretty costly. They're going to range anywhere from $1,500 to $2,000 on average per event, and the loser has to pay those fees. In addition, it cannot be appealed or disputed. So, we've already seen a lot of states come online with their arbitration plans. And I really hope that we can really shift into a little bit more preventive arena. One of the complexities around the law is that today we have 18 states that already have balance bill protections and provisions on the books. And you would think with 18 states, there's not going to be a very large lift when the federal legislation comes online. However, those 18 states only cover about 16 to 20% of the population, depending on which state you're in. And that's because those large employee groups make up a majority of the membership in America now. And of course, that's governed by federal legislation. And so if you are a provider or a payer or even a vendor that's working in a multi-state arena, it's going to be pretty important for you to understand what exceeds, right? Is it the state or the federal provisions? One of the best sources that I have found, and I've done a lot of research around this on the internet, comes from the Commonwealth Fund and Mr. Manasa Koma. And he published this website. It's here in the source information, and we'll try to leave this in the chat as well. I really encourage you guys to go out to this website if you haven't already. In it, there's an interactive US map, and you can hover over these states, and up will pop up the state laws that govern the state for now. And then in addition, there's a table-driven source that you can click on, and it will show what I have over here on the right-hand side, which is a state breakdown. I'm really looking to understand what are the provisions within that state. However, I really wanted to take some time here to talk about that, right? What's the difference between state and federal? Because I think it's confusing. And I think a lot of it is going to have to be really maybe shooken out in lifetime once we get implemented. However, let's just take an example and look at Texas. So Texas, I'm pretty excited about what's happened here in Texas. We've got the SB 1264 Texas Act that went live in January 1st, 2020. And the TDI did release the first biennial report, and it showed really surprising good results as far as what's happened within that state around surprise billing. I would caution that that's also a time frame that captured some real COVID impacts. So it's quite possible that we might see a shift in those results in the next year as the next report comes online. However, as you look at this, what I've done here is tried to break down the difference between the state and federal plans around this. So looking on the left-hand side, that is the state provisions that are on the books today. The right side is the federal piece and what the changes are. So obviously we talked about the plans covered, right? that your PPO, your EPO, and your HMO plans are covered, as well as your employee retirement system and the Teachers Association, which of course is quite large in the state of Texas. However, those self-funded and ERISA plans and large group plans are not covered. And so that's going to be a very hefty lift of members coming online. The services covered are about the same. And, just of course, here we're just using Texas as the example, but I would pay particular attention to your ambulance as well as your air ambulance. The federal provision has written in it some air ambulance coverage, and I think that's important to note. It's one of the first shifts that we've seen in that area. Looking down, we'll see the initial payment for the state today. It's made up of usual and customary rates or an agreed to rate. That's quite unusual compared to the federal legislation, which is going to be determined by the health plan. So let's just walk through this for a second. Today, you go to the doctor, you go get surgery, you have your knee surgery, your anesthesiologist is out of network. The provider typically is going to bill your plan for those services. If the plan is in tune and connected with their contracts, they're going to deny that claim. It's going to go back to the provider. The provider is going to pick that up and push it out to the patient as a balance bill. Starting on January 1st, the plan will deny that claim. It will go back to the provider, and the provider has 30 days to do open negotiations with the state plan. After such time as they have about 4 days to file an IDR process. Here's some additional provisions of the legislation and what you would look to do. There's some more rules around bundling and payments. Really quickly, I also just want to bring up the clause we talked about earlier. One of the requirements is that you have to get this notice of consent. And I think that's pretty important. There are definitely states right now that have pieces of legislation that protect the consumers around consent. Consent is really held up to the ethics of a physician code. And so it's not so much as just signing a waiver, of course, when they're receiving care, right? There's a lot more protections or an oversight around consent. And there are some states that don't recognize it at all. So I would absolutely look at your state and try to understand when it comes to those waivers and what is required of the facilities to perform now, how are they facilitating that and what does that look like for them? In addition, I would say understanding that some of those states have written into their own state plans that they have the ability to follow the federal legislation when it comes online. Is also, I think Washington has that written into their state legislation today. So they've kind of protected themselves to have a heftier ruling when the state or the federal legislation came along. All right, let's talk about the second piece of legislation, which I think is going to be really impactful, and that is the price transparency rule. Going into effect July 1st, 2022, the price transparency rule really requires both hospitals and insurers to reveal long confidential pricing data. That includes the rates that they pay for services, historical service amounts, mandates of underlying negotiated amounts. It's written pretty simply. It's just got two predominant mandates around it. And as you guys know, this has evolved quite extensively. So during the first half of this year, we saw a lot of additional rules from CMS and additional guidance from CMS come out around this. But here it is in its simplicity. The providers have to write a comprehensive machine readable file with all items and services. In addition, they have to display a shoppable service in a consumer-friendly format. Now, the transparency rule and this No Surprise Act really act as a 1-2 punch, right? It's going to serve as a catalyst for payment reform in the U.S. healthcare system. And it's really going to usher in the age of consumerism. A recent poll demonstrated that 3/4 of patients really look at price transparency ahead of accessing care. meaning that the digital transformation is not only critical to the quality of care that they're receiving, but it's really critical to the economic decisions around their care, or if they get care at all. And one of the largest issues with that is that that type of atmosphere can cause patients to neglect their care. And if they 1 out of 3 are going to really forgo care whatsoever, if it puts them in a position of having and incurring medical debt. At the bottom of the slide, I've included a screenshot from an article maybe many of you have read from the New York Times. If you haven't, I highly encourage you to go out there and look at this. When you go out to the website, this is what you're going to see. You're going to see this as a scrolling title banner. And in it, you'll see the price for an emergency room X-ray at Baylor Medical Center in Dallas for a United plan is $971. With a Blue Cross plan, it's $1,727. With no insurance whatsoever, it's $832. Now, this article is written by Sarah Cliff. Sarah Cliff is a preeminent writer for the New York Times in the health sector. But I would say, and there's a lot of great information in it, but I would say overall, it doesn't really talk about the complexities of the financial triangle that we have between a provider, a payer, and a patient when it comes to care. One thing that this article doesn't talk about is the allowed amount or contractual rates, or the fact that typically contracts between providers and payers are negotiated at a TCV level, a total contract value. They're not negotiated at a FootX rate level. It doesn't mean that I haven't seen emphasis on special areas of care or codes talked about through a contracting negotiation. However, most of the time it's a much more broader discussion, and this is not on really the docket. And so, why would CMS post these 2 requirements out there if they knew that it wasn't going to really allow for a shoppable venue for the consumer as of today? And CMS is quite candid. They agree with that. They know that given the allowables and the cost shares, it doesn't create a shoppable market quite yet. But the goal is really to enable and foster private sectors and other vendors to come in and really use data analytics and understand shopping behaviors to really change the culture around the industry. It's going to allow those secondary vendors to help create just a much more consumable market overall. So those are the 2 pieces of legislation, and this is the implementation timeline. Most of you have probably seen that the price transparency did slip a little bit on the date. It was set to go on January 1st. They've moved that to July 1st. And I understand that it's quite possible that we would see some additional slip. However, I do believe that these 2 laws will be fully enacted and hopefully adopted during this next year. So those are the mandates, and this is the timeline to implement. But probably more importantly, what does a health organization or a payer organization do? The US healthcare system is shifting to consumerism, right? They want that shoppable market. We are seeing where there's a real focus in the provider community shifting specialist revenue capture, really focusing much more on the patient's journey and navigation, which is really essential. We believe on the other side of this, the ones that do adopt this are really going to find additional value, and they're going to find more membership capture. I think it's also pertinent to just give a warning that we're seeing some vendors out in the marketplace just reposition products so that they're consumer friendly. However, they don't meet the and that's a great place to start, right? But they don't meet the mandates of the legislation as presented. So I would absolutely lean on consultants or advisory panels to really help make sure that you're securing the correct technology and tools and services, and most importantly, partnerships. I would also encourage to find the value. Engage with products that are really infused with digital innovation. You saw within the mandates, those go clear out to 2025. So while we're dealing with the ones that are on the table today, there's more coming. So those that get ready for the long-term requirements are probably going to be best suited. And then I would also encourage to think broadly. What are other areas that really mimic the US healthcare, but sit more in a retail sector that you can lean on for understanding? Media, retail, financial services. Where can you find those other areas and think innovatively about the value add to your own organization? Just stepping a little bit deeper, here's the areas of focus that we would advise. We definitely would, again, I've said it a few times here, lean on your advisor services. This is complex stuff, right? And typically, just with a lot of CMS guidelines, they're guidelines, they're gray in nature. And so I think there's going to be a lot of dialogue about the what ifs. What happens with value-based care? What happens with bundled payment arrangements? What happens, I've sat in payment integrity for 20 years. What happens if a claim that has gone through arbitration gets all the way through the life cycle, only to be picked up in an audit selection at the tail end of its journey? I don't think that's going to be very well received by the provider community, right? So what happens in all of those scenarios, and to really kind of think through those. So that's the first thing that we would say, is just to really make sure that you're securing your advisory and your SMEs that know it. And if you don't have those internally, seek them externally. I would also say facility readiness. Those of you that lived through HIPAA, there was a small form that was required for HIPAA, signed in all those facilities. And that small form proved to be a rural headache. Rolling out a form across the United States is a pretty big deal. And I would also say that those facilities, staff members need to be able to articulate how to speak around prices and cost share. And from the payer side, both payers and providers really would benefit by being more engaged with those patients on the front end. What does your call centers look like? How are you having those conversations with those members around that? And around this legislation? Only about 9% of America understand that this legislation is soon to be enacted. And so I would say you probably need your patients' help. Reach out to them through a call center is a good tactic. Data analytics, really understanding where your risks are. Where are you most exposed? I had an opportunity to watch a single state Blues plan do something really unique to them. And I won't call them out by name, but they had long sought a partnership on a contract with their ambulance inside their state and were unable to get contracted. And when this piece of legislation came on live, they really held the chips to be able to do that much more aggressively so. But instead, what they, it's a highly member-centric plan. What they did instead was to sit down and come to the table and really negotiate a contract. They are contracted now with their ambulance. And so they get to completely forgo arbitration altogether. So really excited to see that they get benefits from that. So really assessing your risk. Where do you have the most opportunities to gain around this piece of legislation, or the most risk? Member support, we talked about that through a call center. The next thing is your RCM pricing, real-time pricing. We've created a pretty dysfunctional triangle between the provider and payer in US healthcare, where it's a pretty adversarial event. How do we get to where we are all utilizing the same source when it comes to payment? A lot of times I hear that the provider community is pretty vilified over this issue. And I would agree, there is definitely, lived my career finding where there's aberrant billing, right? But I would say that there is also a lack of understanding that you don't necessarily have the tools to meet the mandates of some of this legislation as presented. And so it is going to be a lift, and finding out how they could do that quickly is going to be pretty important. And then lastly, with arbitration prevention and then support. right? We really want to believe that if you're getting on the phone with those providers and those members, you have the ability to really prevent arbitration. Also, you can lean on your adjudication team, making sure that you've got filters in there to really capture these if missed. And then lastly, your contract management and digitization. Not a big secret. Most payers really struggle with the management of their contracts and how they can digitize those so that they become much more able and agile to be able to hook up data analytics and AI around. So these are the requirements of the Act, kind of spelled out and put in a summary form for you. Again, we talked about the emergency department setting. They have to have a protection in place for emergency services. Again, you hold harmless the member. They're not financially responsible for any portion of that bill beyond the in-network cost sharing amount. So that is the high-level rules. And again, this is the strategy just at a summary level that we would really encourage payers and providers to really lean on. And lastly, I would just say, healthcare organizations that work to not only meet the mandates of this legislation, but really work to drive the value around it, are going to find real opportunities. I think they're going to loosen the third-party payment problems by giving administrators cost around revenue management. I think some of the large volumes of payment integrity issues lessen greatly. I don't think they probably ever go away, unfortunately, but we definitely would see those start to shrink. More importantly, we have $140 billion today in medical debt collection. It has been a real strife on Americans. And so I am really excited to see this legislation be enacted and supported so that we can get on the other side of that patient's journey and ensure better care. All right, those are the points I really wanted to share with you today. I ran through that pretty quickly, but I am absolutely open for questions.
Thank you, Tina. As a reminder, you guys are able to submit any questions using the Q&A function at the bottom ribbon of this Zoom meeting. The first question we have, Tina, out of the 7 modules of focus, where should a Blues payer focus first?
Yeah, that's a good question. I would say, understanding where are your points of pain today? Where has this legislation not been online to serve your members? And how can you really help share member awareness around that? I think is pretty important. I'm not seeing these 2 pieces of legislation talked about enough. And it could, there are gag orders. I would think by January 1st, some of those gag orders are lifted so that it can be discussed, and those are on the provider side. So certainly not in this arena. So I hope everybody asks their questions. But I think speaking to the members about this is pretty important. I would also say that getting to the table to have those discussions with those entities that are targets for contracting that you haven't been able to target before is pretty important. Arbitration, I don't think it's just the costs around arbitration. I just don't think that's where healthcare dollars should be spent, right? And I'm assuming many on this call would agree with that. It would be nice to see that be the last course of action as opposed to the first. And so how do you look at it from those eyes and find out where is the appropriate place for you to put your focus?
Thank you, Tina. Our next question, you talk about adoption in order to drive value. What is a value that the Blues can expect through adoption?
So, I have small children in elementary school and I have adult children. I have millennials. I have 2 millennials that are adults. When I want to make an appointment for my younger children. I get out my Rolodex and I call my doctor. That's always been our doctor, right? When my adult millennial kids want to make an appointment, they get on their phones. They are looking to understand what are the reviews of that provider. What are their billing practices? How far are they? How convenient are they? Can they get in and get scheduled? They're standing in line waiting for their Uber, and they're doing all that from their phone and their devices. And they absolutely are the generation that are going to need to know about the economical outcomes of their care. And so I would say, I feel like this is a larger lift for the provider community overall. They need tools to be able to help them get there. But I would say the payer community can help in that. They can help by really working to stay just as innovative on that technology with those members, right? And putting technology and those sites on their phones, on their devices, so that they have access to them. It's just a different consumer. And so I would encourage you to start there.
Thank you. Our next question regarding this topic, where are the Blues at most risk? What is the impact for Blues?
So I shared with you at the opening that I've been a student of ITS exchange claims for quite some time. And I think for the most part, those exchange claims go through the process and programs as planned. I also think that there is a large administrative burden around those claims. And I also have witnessed where not all of those are processed the same. And so I think it's a concern that plans should really be looking at their ITS claims and partnering with their fellow Blues to really make sure that they have got a vehicle to really push those claims to their appropriate places if they look like they're at risk for being balance bill. So if they're out-of-network claims for an ITS claim, what are you going to do and how are you going to get those back to the right parties immediately for correction? And what does that look like? So I think that's a very large risk to the Blues. Not that it will be more costly, it will just be missed capture opportunity. Of course, you want to start at the beginning to really drive the impact. And I really do appreciate everybody's attendance. Here's my contact information. Happy to speak about this topic directly, but thank you very much for your time. Have a good afternoon.